Yeah, this is Dr. Vijay Anand Reddy. I'm the director of Apollo Cancer Institute, Hyderabad, and we have an excellent oncology team, many surgeons, around 20-22 surgeons, with site-specific surgeons, robotic surgeons, head and neck oncology department with half a dozen head and neck oncologists, surgical oncologists, and we have gynec oncologists, we have uro-oncology surgeon. So we have a dedicated site-specific surgical oncologist and 6 medical oncologists, and we have hemato-oncologists, and we have site-specific radiation oncologists in the department. We have 11 radiation oncologists who are site-specific, right from head and neck to thoracic and abdominal, gynec and uro radiation oncologists. And we all work as a team, and we all have a ethical tumor board. All complex cases are discussed in the tumor board every week. Besides that, we have an excellent teaching program for the postgraduate students, right from Monday to Saturday. We have general clubs, seminars, teaching schedules, grand rounds. So every student, every doctor has to participate in these teaching programs. 1 hour a day in a corporate sector, which is, I always feel proud that in a corporate sector that we are able to manage 1 hour of our time for the teaching purposes. This is in brief. We are associated with the entire Apollo group in the tumor board meetings, clinical discussions, and sharing of knowledge and sharing of the infrastructure across the group. That's where the goal is to get the best outcome for our patients. So that's our goal in that regard. We don't mind sharing our infrastructure and shifting the patients from our center to other centers and welcoming the patients from other centers to our center. Yeah, proton is certainly a new tool in the radiation oncology. We all know the radiation oncology is mainly on the computer technology that it works, and last 2 decades have been leaps and bounds of transformation has happened in the way the treatment is delivered to these patients. So from 2D to 3D CRT to IMRT, image-guided radiotherapy, and stereotactic body radiation therapy, and now the proton therapy. So ultimately, we all know the 2 important things when you're treating a patient are the quality of life, maintaining the quality of life, besides achieving a cure. So in terms of reducing the morbidity and maintaining the quality of life and without compromising on the cure is the goal for the radiation oncology when they are delivering the treatment for any type of cancer from head to toe. So in that regard, I would certainly say that proton definitely has an edge over the existing photon technology in terms of reducing the dose to the structures which are close to the target. So obviously the quality of life and the morbidity would be much less. Especially in certain areas, definitely the proton scores over the photon, especially in a pediatric age group, head and neck malignancies, treating breast to reduce the dose to the heart and lungs, and treating prostate to reduce the dose to the bladder and rectum. So and so forth. There are so many advantages that you have with the protons. Having said that, I am not saying proton is for all patients. We need to have a clinical judgment, explain the pros and cons, cost versus benefit, because it comes with a cost. Proton therapy comes with a cost. So whoever can afford or wants to have a better treatment facility in terms of reducing the side effects, certainly we should offer them. And if they all understand the pros and cons of a better technology, we should always help them to and support them and encourage them to go for it. To be honest, we know the radiobiological effect of photon and proton does not differ much. So we are not harping on saying that the proton gives you better results or better outcomes compared to the existing photons. But having said that, over a period of time, there are so many trials going on to prove the fact that the proton may give better results compared to photon. The logic is that when you know that the patient is tolerating better, we can deliver theoretically higher doses compared to photon therapy, and when the patient tolerates the treatment well, the chances of delivering better treatment and higher doses may result in better outcome. That is the logic behind what when we say proton is better than the photon therapy. But over a period of time, when you come out with the results, some trials certainly are showing that the proton is giving better locoregional control and better cure rates, but the data is still immature, a very small number of patients. And once we get into phase 3 randomized trials, and once we get the results out of that, then we can be dogmatically saying that. This is very important. From day one, Apollo has always been harping on discussing in a multi-tumor board approach, multidisciplinary approach. That's been the policy of Apollo Group Oncology Centers. So every complex cases would certainly get into the proton therapy. There's so much of buzz about the proton therapy in the country. People just come into your office and ask for a proton therapy. So we don't inadvertently treat every patient on proton. We would always discuss every patient who comes for or who is sent or referred from a clinician for proton therapy to discuss in the multidisciplinary tumor board, where every specialty is involved. The radiation oncologists, medical oncologists, surgical oncologists, pathologists, pertaining to the surgery, neurosurgery, whoever it is needed for that particular case to be discussed, we would certainly discuss and understand the biology and the stage of the disease. Then we would look at multiple factors and then decide whether this patient is going to be benefited by doing proton therapy. So that will be conveyed to the patient, the advantages of getting the treatment with proton, and then only once the tumor board, the multidisciplinary board is convinced that this patient is going to get a better or a benefit compared to the photon, then those patients would be advised a proton treatment. Yeah, that's a wonderful question. So we have come a long way ahead. Initially it used to be just a thumb proton therapy with huge machinery and huge blocks to protect the critical structures here and there. Now that has moved from there to the IMPT, which is intensity modulated proton therapy. That's a pencil beam technology. That's a huge difference between the previous proton a decade back and the present proton, where the pencil beam moves from layer to layer in the target and delivers the required dose and then stops wherever it needs to be stopped. So that's a latest technology, which is IMPT. Earlier we never used to have multi-leaf. Now we have got multi-leaf, and now also that we have multiple level of energies depending on the depth of the dose, the depth of the target that we are dealing with. So multiple level of energies, multiple MLCs, and so this is definitely helping us to deliver a good amount of dose, required dose to the target, and protecting the structures around the primary target. So there's a huge development that has happened, and we are still looking at static IMPT presently. Now that's going to become an arc IMPT. So with static means the beam standing at one area and delivering the treatment. Now it's going to move to the arc treatment, where arc while moving the gantry, you are delivering the radiation to the patient. So which is normally available with photons, now we are going to have with the protons. Besides that, the radiation is delivered over a period of 5 to 6 weeks. Now we are going to develop a treatment called flash therapy, which is possible only with the proton, delivering the entire radiation in one single go. So the days are not too far. We are probably going to get that flash therapy also, which is going to be introduced in the present technology what we have it in Chennai, and we are also planning to have 2 proton other than Chennai, one in Hyderabad and one in Delhi. I'm proud to say that Chairman has always been very encouraging on 2 important things. Patient comes first. So to deliver the best treatment to the patient, we need to have good interactions, clinician discussions, and what is the latest which is happening across the globe has to come to India. So we have started this Apollo Cancer Conclave way back in 2003, and we did several such meetings in Hyderabad, Chennai, and this is the first time that we are doing it in Mumbai. You look at the number of delegates that's participating, more than 2,000. That's a very good to start with, and it looks like one of the major international or a national conference, and we have good participants with all the halls filled with the audience and so much of interaction going on. We are going beyond schedule because there's so much of interaction, so many questions, and they are so excited about participating in Apollo Cancer Conclave in Mumbai. And it's so gratifying making such huge efforts by the Apollo Group, spending so much of money and efforts on academics to get the best treatment for our patients. So we always acknowledge that and thank you our management for helping us and backing us for such academic endeavors.